Today we'll be looking at type II diabetes mellitus. This is a condition where there's a loss of blood glucose regulation, which leads to hyperglycemia. It is due to insulin resistance, which is often caused by what we call the metabolic syndrome. There is a 4 to 6% prevalence, and type II accounts for 90% of all diabetes cases. Most cases have adult onset. However, there is an increasing incidence in teenagers. This disease disproportionately affects people of Māori, Pacific, South Asian, African, and Caribbean descent. To understand the pathophysiology of type II, let's first review the normal regulation of blood glucose. We see here that glucose from the diet is absorbed from the GI tract into the bloodstream. The pancreas is important for the regulation of glucose levels. Now, glucose is needed by the brain, and other important tissues for the regulation of glucose are the liver, muscle, and adipose tissue. Glucose is able to cross the blood-brain barrier and thus can enter and be metabolized. In other tissues, however, special transporters are needed to increase glucose uptake. In the pancreas, beta cells respond to blood glucose levels greater than 5.5 by releasing the hormone insulin. So once this enters the blood, it can bind to specific insulin receptors on cells within insulin-dependent tissue. One of the major effects is increased expression of GLUT4 glucose receptors. This allows increased glucose uptake from the bloodstream. Other effects of insulin are on the enzymes of metabolism within these tissues. There is increased glucose uptake and increased glycogen production for storage in the liver and muscle. In adipose, there is increased lipid storage. Production of new glucose is reduced, as is glycogen breakdown, and lipid breakdown is also reduced. Therefore, insulin release overall causes a reduction in blood glucose levels. So if there is insulin resistance, we will have increased blood glucose due to reduced intracellular effects of insulin. Over time, diabetes will develop. So let's look at the pathogenesis of type II. The first step is insulin resistance, which occurs due to lipotoxicity when there are more free fatty acids. A major contributing factor to this is the metabolic syndrome, which consists of BMI higher than 30 plus 2 of the following: dyslipidemia, hypertension, and fasting glucose higher than 6.0 millimoles per litre. Lipotoxicity leads to inflammation with the release of cytokines interleukin 1b, interleukin 6, and TNF. This causes deposits of free fatty acids in the liver and muscle, resulting in reduced signaling. In adipose tissue, there is reduced peroxisome proliferator activated receptor, which leads to a reduction in adiponectin, which is an anti-hyperglycemic. Following the onset of insulin resistance, there is beta cell compensation. This is via proliferation and hypertrophy of the cells, such that they produce more insulin to maintain normoglycemia. Over time, however, beta cell exhaustion occurs. This leads to impaired glucose tolerance, and amyloid deposits in the pancreatic islets start to cause destruction of beta cells. Finally, there is a loss of regulation over blood glucose and hyperglycemia. This is when we can diagnose type II diabetes. Speaking of metabolic syndrome brings us to the presentation of type II diabetes. Now, approximately a third of the population appear to have the metabolic syndrome. However, most cases of type II are asymptomatic, picked up by routine testing. Symptoms can include fatigue, glycosuria due to blood glucose levels exceeding the renal threshold, which leads to polyuria as a result of osmotic diuresis. Nocturia and thirst are other possible consequences. Undiagnosed hypoglycemia can also mean diabetes presents with complications including retinopathy, neuropathy, skin infection, cardiovascular disease, and stroke. These complications are estimated to already be present in 25 to 50% of patients by the time of diagnosis. So let's consider the diagnosis. Look for evidence of complications, particularly in the feet and eyes. Retinopathy can be picked up by an ophthalmologist. Blood pressure is high in around half of patients. Investigations to consider are blood glucose, a fasted value higher than 7 moles or random higher than 11.1 moles will be diagnostic if the patient is symptomatic. Or in asymptomatic patients, we need 2 abnormal values to diagnose. HbA1c is a measure of glycated hemoglobin, which is much less transient than blood glucose. Less than 40 millimoles per mole is normal, while 41 to 49 indicates prediabetes and higher than 50 indicates diabetes. A 2-hour postprandial glucose level between 7.8 and 11 millimoles per litre is indicative of impaired glucose tolerance. This is associated with an increased cardiovascular risk and high risk of developing type 2 diabetes, but you will not have the same risk of other complications as with diabetes. Other tests to perform are a full blood count, urea and electrolytes, liver function tests, lipid profile, urine protein, islet autoantibodies to exclude type 1 diabetes, and a cardiovascular risk assessment. Let's look at the possible complications of this disease. These occur particularly in undiagnosed or poorly controlled diabetes due to the effects of hyperglycemia on insulin-independent tissues, which mainly include blood vessels and the eyes, nerves, and kidneys. Blood vessels are affected in the endothelium and smooth muscle cells, as well as T cells and macrophages. The first mechanism of damage is via age-range signaling. With hyperglycemia, we have increased formation of advanced glycation end products, which bind to RAGE receptors on the surface of cells. This leads to increased production of reactive oxygen species, trapping of LDL, causing atherosclerosis, and trapping of albumin, which causes basement membrane thickening in capillaries. The second mechanism of damage involves activation of protein kinase C, which triggers increased activation and adhesion of T cells and macrophages. Also, mesangial cells found in the glomerulus of the kidney produce TGF-beta, which causes extracellular matrix and basement membrane deposits. The process of activation is intracellular in response to increased glucose and diacylglycerol, promoting protein kinase C, which has these effects. The final mechanism of damage is the disturbance to polyol pathways occurring within other tissues. Within cells, increased glucose leads to formation of sorbitol and fructose via specific enzymes. These reactions require NADPH, which is also needed for production of glutathione. So depletion of NADPH means there is less production of the antioxidant glutathione. In addition, increased sorbitol results in osmotic stress, and there is oxidative stress as well as increased age production. The result is cell damage and death. This can lead to neuropathy, retinopathy, and nephropathy. We will now look at how these complications can manifest in the body. Macrovascular may present as cerebrovascular infarct or hemorrhage. Cardiovascular effects may include myocardial infarction due to accelerated atherosclerosis, as well as hypertension. Also, peripheral arterial disease can occur. Microvascular complications may present with ocular lesions, including cataracts due to glucose being converted into sorbitol, resulting in osmotic pressure and clouding. Glaucoma can occur, and retinopathy can progress from early non-proliferative, where there are hallmark microaneurysms, macular edema, and various exudates, to proliferative retinopathy, where vascular endothelial growth factor causes angiogenesis and can lead to intraocular hemorrhage or retinal detachment. In severe cases, this can lead to blindness. Renal disease is important to consider in diabetics. Glomerular lesions are common and can include capillary basement membrane thickening, diffuse mesangial sclerosis, and nodular glomerulosclerosis. Enough damage to many glomeruli can lead to nephrosclerosis and renal failure over time. There is reduced renal parenchyma and ischemia, with a pale and granular appearance. Pyelonephritis is inflammation of the kidneys, which can be acute or chronic, and can lead to papillary necrosis in which the renal papilla die. Renal artery atherosclerosis can also contribute to progression into chronic kidney disease in diabetics. Finally, we will consider peripheral neuropathy. This occurs due to small vessel damage, axonal damage, and increased permeability of capillaries supplying the nerves. 80% are symmetrical, sensory, or sensory-motor neuropathy. However, mononeuropathy, such as sudden drop foot or cranial nerve palsies, can also occur. You may also see autonomic neuropathy affecting the bladder, bowel, and sexual function. How do we manage type 2 diabetes? In all patients, start with lifestyle factors such as weight loss and exercise, and education to understand the risks and benefits of good control. Diet and smoking cessation are important. Metformin is the first-line drug, promoting insulin sensitivity while reducing hepatic glucose release. It is good in that it does not cause weight gain or hypoglycemia. However, there is a risk of lactic acidosis in those with a low eGFR. Gastrointestinal effects may include diarrhea, discomfort, and loss of appetite. So the next alternative or additional drug class is sulfonylureas. These increase insulin secretion, however, they do carry a risk of weight gain and hypoglycemia. So if they are not tolerated, thiazolidine diones are an alternative. They act by increasing peroxisome proliferator activated receptor gamma, leading to increased insulin sensitivity. They are good if there is a risk of hypoglycemia, but should be avoided in congestive heart failure patients. So the next stage of treatment will be insulin. This can be given as long-acting basal doses such as glargine and short-acting bolus doses such as aspart. There are many types of insulin which we won't go into. As an alternative or addition to insulin, we can consider GLP-1 analogues, which enhance the incretin effect and thereby increase insulin secretion. The first type are GLP-1 agonists, such as exenatide. The second type are dipeptidyl peptidase 4 inhibitors, and both of these are good as they can promote weight loss. Now there are other drugs that can be used in this pathway, and this is certainly not an exhaustive list. It is important to educate that most patients will eventually need insulin. This does not equate to a failure on their behalf, but is part of the disease progression. Now, follow-up of patients with diabetes is important. First, we want to assess glycemic control by measuring HbA1c and asking about medication compliance, identifying any barriers. The target HbA1c should be 50 to 55 millimoles per mole, or as otherwise agreed upon. If glycemic control is poor, consider treatment progression. Secondly, global vascular risk or cardiovascular risk assessment should take place, including blood pressure, lipid profile, smoking status, and weight. Annual retinal screening is important to detect possible retinopathy, and foot examination should check for ischemia, neuropathy, infection, and ulcers. In addition, measure renal function and ask about hypoglycemic episodes, which are a possible serious side effect of medications.